So hello, everyone. My name is Laz Boris, and I'm the president of the Thyroid Foundation of Canada. I'd like to welcome you to our April 16th public education webinar. Our guest speaker today is Dr. Antonio Bianco, who will be speaking on his book, Rethinking Hypothyroidism, Why Treatment Must Change and What Patients Can Do. Dr. Bianco is a professor of medicine and a member of the Committee on Molecular Metabolism and Nutrition at the University of Chicago, where he runs a laboratory funded by the National Institutes of Health to study thyroid hormones. He is also a former president of the American Thyroid Association. Once the presentation has been completed, Dr. Bianco will answer questions from the audience. Catherine Keene, our administrator, will be acting as producer for this webinar. This means that she will be managing the technical aspects of Zoom. Some of our board directors will also be assisting. Anista Primachagran will be looking after the Q&A section. Lori Martin will assist us in the chat room. This event will be recorded and made available on our website later this week. So if you happen to have missed it, tell your friends. If your friends have missed it, tell them that they can see it later on. Before we begin, I'd like to go over some housekeeping. We use the webinar functionality of Zoom. This means that you can see and hear the presenter and support team, but your audio and camera are not active. Please have a look at the controls at the bottom of your Zoom screen. We are not using the raised hand feature. Please use the Q&A feature, the question and answer feature, to ask your questions. You're able to communicate with other attendees using the chat feature. So please feel free to join in. If you have any technical issues during the webinar, please reach out to Catherine via the chat feature. At this point, we're ready to begin with Dr. Bianco's presentation.
Just a second. Okay, can you hear me well? Can you see my slides? Hello, everyone. Thanks very much for joining. It's a pleasure to be here. I'm going to say how grateful I am for the foundation to have me as a speaker today. I'm going to be talking about rethinking hypothyroidism, and this is an educational presentation. So I want to make some disclosures. I am a consultant for a number of pharmaceutical companies. However, I do not own any stocks or stock options or shares, and I do not own any patents involved in the treatment of hypothyroidism. So my role is simply as a consultant for these companies. So why are we here today? We are here because as a group, patients with hypothyroidism that are treated with levothyroxine and have a normal TSH levels exhibit reduced quality of life and impaired cognitive functions such as learning, memory, attention, and cognitive speed. That's a fact. And we're going to talk about a little bit more about this later. They also have some metabolic issues. Levothyroxine treated patients with a normal TSH, and I emphasize normal TSH levels. They exhibit slower metabolic rate. Their rate of metabolism slows down. They weigh about 10 pounds more. This has been scientifically documented, and have higher cholesterol serum levels. So that's so they have a cognitive issues, and they also have metabolic issues. Now, some patients, perhaps 10 or 20%, we don't know exactly. Some people think it's more, some people think it's less, seem to be particularly impacted by these residual symptoms, okay? Those symptoms reach level that becomes clinically relevant. However, Unfortunately, many endocrinologists dispute these facts. They don't accept this as a product of the serious scientific investigation. And so the patients who feel the symptoms, they complain about a perceived culture of dismissal by their physicians. There's a shock. The physicians believe that once the TSH has been normalized, all the thyroid-related symptoms must have been vanished. And the patients have a different experience. And that creates a friction between physicians and patients. Now, obviously, we want to fix this. How can we fix this issue? Well, before we think of a solution for this problem, we need to understand why patients that have hypothyroidism and are treated with levothyroxine and have a normal TSH level, why do they have residual symptoms to start with? Well, there are probably a number of factors that contribute to the residual symptoms: age, sex, genetic background, and the existence of other conditions, other chronic illnesses that can create symptoms that are very similar to those residual symptoms caused by this hypothyroidism. Menopausal syndrome is one that, in my experience, is confusing sometimes with our patients with hypothyroidism. However, there's a low-hanging fruit, what I call, that can be addressed immediately. Even though we do not understand everything about these residual symptoms, there's something that we do understand, and we have to face it. Treatment with levothyroxine alone is not physiological, meaning it does not replace the thyroid gland. It fails to restore normal thyroid hormone homeostasis. What do I mean by that? Well, let's go back a little bit and understand some fundamental principles of thyroid physiology. How does the thyroid work? The thyroid makes basically two hormones. One is called T4, the other one is called T3. And the numbers have to do with the number of iodines in the molecule. T4 contains 4 atoms of iodine, T3 contains 3 atoms of iodine. Now, one thing that needs to be absolutely clear: T4 is an inactive hormone. It's a prohormone. T4 doesn't do anything. It's a pre-hormone. It needs to be activated. T3 is the active hormone. T3 is the hormone that resolves symptoms of hypothyroidism. T4 does not resolve symptoms of hypothyroidism. Therefore, when we think about, well, thyroid is important for development, for growth, for metabolism, for cognition, we are thinking, yeah, T3 does all of these things. T4 does not do those things. Now, so T3 is really important. Where is T3 coming from? Interestingly, the thyroid secretes a little bit of T3 only. Most T3 is produced outside of the thyroid gland. So let's give some numbers so we can understand. A normal adult with a healthy thyroid will produce about 30 micrograms of T3 per day. However, the thyroid only produces about 5 micrograms. Where's the rest coming from? The rest comes from this metabolism of T4. T4 is metabolized to T3. There's an enzyme, there are a couple of enzymes that pluck out iodine from T4, making it T3. These enzymes are called deiodinases. They remove an atom of iodine from T4, making T3. So that's a big deal, because T3 is such an important molecule, but most of it is produced outside. But on the flip side, the thyroid also makes some T3, and that is probably really important, and we're going to see in a minute. Now, the concept that I actually only learn or realize that this is how it is that the thyroid system, and I mean the thyroid system, I mean the pituitary gland, the hypothalamus, and the thyroid itself, they are hardwired to defend serum T3 levels. What I mean is, when we manipulate the thyroid system, we see that there's large fluctuations in TSH, in T4 levels. However, one thing remains always constant, which is the T3 plasma levels. So the system is geared to preserve and defend T3 levels in the circulation. This is really important. Now, what happens when you don't have a thyroid, right? This is the system. The system is focused on preserving T3, but when you don't have a thyroid, either because you've had thyroidectomy or because you have Hashimoto's disease or genetic conditions, and we treat you with levothyroxine, we rely on these deiodinases to produce all the T3 that we need, right? That you need. So these deiodinases are centerpiece for the effectiveness of the treatment of hypothyroidism. Doctors provide T4 through levothyroxine, daily tablet, and the deiodinases produce T3. Now, the question is, can the deiodinases alone, without that little component that the thyroid had, preserve and defend blood T3 levels in patients taking levothyroxine? That's the key question. Can we normalize this thing? Unfortunately, the answer is no. And here is I learned when I went to medical school, the answer was yes. Okay, I learned from my professors that yes, the deiodinases will adjust themselves and produce all the T3 that the patients need. We are so certain of that, you know what? We don't even measure T3 levels in patients treated with levothyroxine. We only measure free T4 and TSH because T3, it's got to be normal, right? It's been normalized through the deiodinases. However, more recent studies have shown that the deiodinases don't preserve serum T3 levels by themselves. Now, when did we discover that? It turns out that as early as 1974, there were hints that this was the case. This is work done by Dr. Jack Oppenheimer, then in New York, published in a very prestigious journal of medicine. Look, here we have T4 levels, and here we'll have T3 levels. In two groups of patients, we have controls, and we have patients treated with levothyroxine. All of them have normal TSH levels, okay? So they are appropriately treated with levothyroxine. Each dot is a patient. And you see that just by looking at the graph, you can tell that the T4 levels in patients treated with levothyroxine are slightly higher than the T4 levels observed in a control matched population. And when we looked at the T3 levels, we see the opposite. We see that the T3 levels are relatively lower than the T3 levels seen in the control population. So what do we have when we normalize serum TSH levels with levothyroxine? We create a situation in which there's a relative excess of T4 and a relative deficiency of T3. Well, this is really important again, and I emphasize why? Because T3 is the hormone that resolves symptoms of hypothyroidism. So this graph should have raised red flags. A long time ago, we should have said, well, wait a minute. We are giving levothyroxine to patients with hypothyroidism, normalizing TSH. Everything seems to be fine. However, we're creating a situation in which we have a relative deficiency of T3. The reds were not raised, the flags were not raised, and we kept going with levothyroxine as being the standard of care for treatment of hypothyroidism. Now, you know what? Maybe the work by Dr. Oppenheimer was a one-off. Was that ever reproduced in other studies? Just 11 studies that I could find on PubMed. Everything here that is in red is a study showing that, yes, there's a relative deficiency of T3 in patients treated with levothyroxine. And you have Oppenheimer, you have Chip Ridgway, you have Sidney Ingber, you have really important people in the thyroid world showing that treatment with levothyroxine creates a situation in which there's a relative deficiency of T3. There were other studies that did not find the difference. Not finding the difference doesn't mean the difference is not there. It could indicate that the studies were underpowered. They were not properly powered to find that small difference. These other studies involving thousands of patients with hypothyroidism do demonstrate that there's a relative deficiency. And more important, is not only relative. About 15% of the patients have T3 levels that are below the normal range, meaning it's just below the normal range. It's not normalized. So even though the TSH has been normalized, the T3 levels are below the normal range. This happens in about 15% of the patients. In all the other patients, you're going to see a shift towards the bottom of the normal range of these patients. Now, this is a big deal. How is that possible that we are normalizing TSH with levothyroxine without normalizing T3 levels? That's such a it doesn't make a lot of sense, because that's not what we learn in medical school. That's not what we learn in conferences that we go. How's that happening? Well, this is the pituitary gland that secretes TSH, this molecule that regulates the thyroid gland. And when we don't have a thyroid gland, we use tablets of levothyroxine to normalize the serum TSH levels. Now, obviously, after a patient takes levothyroxine, T4 gets converted to T3, but both T4 and T3 can feed back to the pituitary gland and slow down secretion of TSH. So that's how tablets of levothyroxine are effective, very effective, in normalizing TSH levels. However, levothyroxine is not that effective in producing T3 outside of this system, outside of the thyroid gland. The conversion of T4 to T3 is less effective than the ability of levothyroxine to suppress TSH. And therefore, we are normalizing TSH thanks to a relative excess of T4 and a relative deficiency of T3. What we want, if tablets of levothyroxine were effective completely in restoring thyroid hormone physiology, we would see normal thyroid T4 levels of T4 and normal levels of T3, and that's not what we see. Now, how did we get to this? I mean, how come we use a treatment for hypothyroidism that is, a standard of care, and yet we don't realize that it's not normalizing completely levels of T4 and T3 in the circulation? How did we get to this situation? Now, let's go back in time quickly and understand that hypothyroidism was described as a disease, as a syndrome, in the late 19th century, in 1880, around that time. And about 10 years later, treatments were developed. The first was a thyroid transplant from a sheep into a woman with hypothyroidism. It worked well, but it didn't take, so it lasted only a few months. And then doctors prepared like a juice from the thyroid gland and injected that juice under the skin. It worked, but it was very painful. It wasn't, you're not going to have those injections for life. Then they realized that you can actually drink that juice, and it's good. It works. It doesn't taste very well, but it works. Then they came up with the idea of eating like thyroid slices for breakfast. And so you would go to the butcher, get a thyroid gland from a sheep or a cow or a pig, and eat maybe a third every other day, and that would make miracles, really fix hypothyroidism. And then finally, around 1900, because the taste wasn't good, they dried the thyroid up, made a powder, put it in a pill, and sold it as a thyroid extract. And that's exactly the thyroid extract that a little bit different maybe after 100 years, but the thyroid extract that some patients use for the treatment of hypothyroidism today. Now, during the better part of the 20th century, thyroid extract was the standard of care for the treatment of hypothyroidism. And we know thyroid extract contains T4. T4 was discovered in 1914, T3 1952. And so we used combination therapy in the form of desiccated thyroid extract as the standard of care for treatment of hypothyroidism. Even though T4 and T3 made by pharmaceutical companies, they were available. And some doctors used T4 and synthetic from the pharmaceutical company to treat patients with hypothyroidism. Dr. Taylor was one in the UK. And he said, well, you know what, T4 and T3 are good in the treatment of hypothyroidism, but some patients really prefer the combination of T4 and T3. This was in 1959. He already realized that T4 was okay, but some patients preferred combination therapy. Dr. Selenko at the Brigham and Women's Hospital at Harvard Medical School, he proposed in 1965 that the perfect ratio of T4 to T3 to be used in the treatment of hypothyroidism was 3.5 to 1, meaning that a little bit more T4, a little bit less T3. But, doctors at the Royal College in London, at Harvard Medical School in the 60s were very happy, and not only happy with combination therapy, but recommending that even when you use synthetic, if you're not using desiccated thyroid extract, a small number of patients will prefer the combination at a certain ratio. Now, in 1970, things changed because Dr. Braverman, also at Harvard Medical School, a brilliant scientist, discovered that T4 gets converted to T3. And so the physicians at that time reasoned, since the body converts T4 to T3, we don't actually have to give a combination therapy because the body, the wisdom of the body, the deiodinases will just adjust themselves and produce sufficient T3. We don't need to. But wait a minute, but how much T4 are we going to give? And that's when Dr. Bob Udiger developed the assay to measure TSH in the circulation. So give tablets of T4 until you normalize the TSH levels. And that became the standard of care for treatment of hypothyroidism until today, okay? But right after that happened, there are reports, and the doctor reports that patients have, well, you know what, I want to go back to the desiccated thyroid extract. I don't like this synthetic levothyroxine because I don't feel very well. Most patients did very well, but some did not. Some patients refused to change, and some patients asked to go back to their original therapy with desiccated thyroid extract. But that didn't change much, and the standard of care remained treatment with only thyroxine or T4. Up until the year 2000, about 2010, between the first decade of the 21st century, a study by the group of Dr. Colin Diane in Wales showed that, in fact, patients that are treated with levothyroxine have these issues with quality of life. They have worse quality of life when compared to a control matched population. This was confirmed in studies by the group of Vilmar Versinga in Amsterdam and in Portland, Oregon, here in the US. So in a space of about 5 to 7 years, we have 3 studies in 3 different parts of the world showing that patients treated with levothyroxine with normal serum TSH levels, they have issues with quality of life and they have issues with cognitive abilities. That's a big deal. And as a result of those studies, the European Thyroid Association, as early as 2012, published guidelines saying, yes, levothyroxine is good. It should be the choice for treatment of hypothyroidism, but be aware that some patients don't do very well on levothyroxine alone. And for those patients, we recommend going back to combination therapy. So this is in 2012. And in 2014, the ATA, the American Thyroid Association, followed suit. They used a very cryptic language. We used a very cryptic language to say basically the same thing. What did we say? We say, well, this is the 2014 ATA guidelines. There's no consistently strong evidence of superiority of combination therapy over monotherapy with levothyroxine. What does that mean? It means both are the same. One is not superior to the other. Levothyroxine alone or combination therapy are equally effective. There could be some, at this point, 2014, there were concerns about safety of combination therapy, which I'm going to address in a minute, but the effectiveness was the same. Well, because they're the same, we recommend against the routine use of combination treatment with T4 and T3 for hypothyroidism. What does that mean? It means don't use for 100% of your patients. Don't use as a routine. So for every patient with hypothyroidism that come to your office, don't use combination therapy. Just use for the ones that don't do well on levothyroxine alone. That's what it says. Maybe this should be written in a more clear way because it is very convoluted, but that's what it means. And to confirm that that's what it means, in the year 2020, the American Thyroid Association, the European Thyroid Association, and the British Thyroid Association published together a statement confirming that that's what they mean. They mean, yes, levothyroxine is the standard of care for treatment of hypothyroidism. Most patients do very well on levothyroxine. However, there's a group, percentage-wise, perhaps 15%, somewhere 10%, 20%. We don't know how much that group is. Those you should give, they do not fully benefit from levothyroxine alone. You should try combination therapy. That's what they said. And I think that that's, it's pretty clear. It's black and white, published in scientific journals. There's not a lot of debate about this. Now, there's skepticism all over the academic world against combination therapy. And the skepticism comes from clinical trials that have been done in which superiority, again, that sentence that came from the ATA guidelines, that the combination therapy is not superior to therapy with levothyroxine. There are about 20 clinical trials showing conclusively that combination therapy is not superior to monotherapy. But that can also be interpreted on the opposite way, right? It means both therapies are equally effective in the treatment of hypothyroidism. But there's a catch. If you do a meta-analysis, and 2 independent groups did 2 meta-analyses, at least, of these studies, the patients prefer combination therapy. Okay, that means when they're blinded, they don't know what they're taking. The doctors are blinding, they don't know what they're prescribing. Even in a blinded, randomized trial, 20 clinical trials, 2 meta-analyses show that the preference is with combination therapy. So in my mind, if we're saying they're both effective and there's a preference for combination therapy, so we should just say, okay, do you prefer this? I don't have a problem giving patients what they prefer as long as I know that both are effective. And there are clinical trials showing that they're both effective. So this is, I think that we should perhaps look at this data in a different way than we've been looking at this data so far. Now, more recently, I was fortunate to be part of a clinical trial that was done at Walter Reed Medical Center in Bethesda with Dr. Shakir and Dr. Hong. And what they did was slightly different. So they did a trial in 90 patients in which they gave to the patients either levothyroxine or desiccated thyroid extract or combination therapy for 16 weeks, each one of these arms. So we have 3 arms. Each arm was, the patients were treated for 16 weeks with one of these 3 therapies. The patients didn't know what they were taking. This was all randomly assigned. The doctors didn't know what they were prescribing. And interestingly, what was the result? Well, the result was that as a group, patients with hypothyroidism responded similarly to therapy with either one of these treatments. So this was not a big surprise. We already had 20 trials showing the same thing. The 3 forms of treatment are equally effective. However, when they looked at the patients that on levothyroxine did not do well, those patients that remained symptomatic when they were on levothyroxine, those patients responded very well when they were switched blindly, randomically, to either DTE or combination therapy. Meaning that maybe when we looked at the whole group of patients with hypothyroidism, yeah, all therapies, either combination therapy or monotherapy, they're equally effective. But if we focus on those patients that remain symptomatic of levothyroxine, those are the patients that really benefit from combination therapy. And I think that that's, again, that confirms what the guidelines have been saying, that a small group of patients seem to benefit from combination therapy. Now, how do we say, oh yeah, for this patient, I'm going to go on combination therapy because levothyroxine failed, okay? Patient remains symptomatic. So before we say that, we need to keep a couple of things in mind. Number one, does my patient really have a solid diagnosis of hypothyroidism? And I think that we see today that the threshold for some physicians to label someone as being hypothyroid, it's very low. And I always like to see, by myself that, or have some form of confirmation that patients have indeed hypothyroidism. And I know that's a big discussion, and I'm sure we're going to talk about this on the Q&A part of this presentation. But if a patient doesn't have hypothyroidism, nothing is going to resolve those symptoms, okay? Either levothyroxine or combination therapy, nothing's going to help because the patient doesn't have hypothyroidism. Well, I'll leave it at that, and we can talk about later. But the other important thing is that there are several other conditions, other chronic diseases that can cause symptoms that are very similar to those residual symptoms. And in fact, those symptoms are not, there's not a single symptom that I can say, oh, this is typical it's called pathognomonic. No, it's not typical of hypothyroidism. No, I don't have. So menopausal syndrome can cause similar symptoms, obesity, vitamin deficiency, other autoimmune diseases. So before the physician says, oh yeah, indeed, I agree, levothyroxine failed for you, we need to exclude other conditions that could cause similar symptoms. And when we do that, and if nothing is apparent, then we say, yeah, probably we should try combination therapy, because that's the only way we can help at the moment. Now, a concern that has been said over the years is be careful with T3. Okay, when I went to medical school, I have to say, oh, T3, don't prescribe T3. It's very dangerous. This is really a problem. You have to be very careful. So, because T3 is the active hormone, right? T3, once patients take a tablet of T3, depending on the dose, you can have side effects. But you know what? Any medication, any drug, any pharmaceutical that we give, and we give in the wrong dose, if it's not an appropriate dose, will have adverse reactions. So there are perfectly established amounts of T3 that can be used safely and effectively in the treatment of hypothyroidism. Now, when we look at those 20 trials, we added about 1,000 patients on combination therapy for up to 1 year. There was nothing. I mean, normalized TSH, heart rate was not affected, blood pressure was not affected. The frequency of adverse reactions was similar to the patients taking levothyroxine. Oh, okay, well, but this is just 1 year. You don't know if in 10 years, we're not going to have any long-term effect of T3 being given to patients. Okay, there was a study in the UK, again, when they looked at 400 patients over a period of up to 17 years. And these patients were taking T3, either alone or in combination with levothyroxine. And you know what? No differences in mortality, morbidity risk due to cardiovascular diseases, atrial fibrillation, or fractures. So we have here 400 patients for as long as 17 years, and they didn't see anything. Again, in Sweden, they looked at 11,000 patients on T3 for about 8 years. This is a large study, and they did not observe increased mortality in this group. So I feel that 20 clinical trials, 2 major populational studies are showing that the rationale, the correct use of T3 in the treatment of hypothyroidism is not associated with increased adverse reactions or poor outcomes. Therefore, I mean, I think that I'm not concerned with the use of T3 when it's properly done. Now, in the interest of full disclosure, last year there was a study coming from Korea in which the utilization of T3 for a short period of time, about a year or two, it was associated with increased heart rate and stroke. But I don't put a lot of value on this study just why? Because we don't know how much they were taking. We don't know their TSH levels. For all we know, these patients could be thyrotoxic. Maybe their TSH was suppressed. I don't know. So I think that I'm just showing it because it is there, and it is true that when given in the wrong dose, when giving it an excessive dose, T3 can be associated with bad outcomes. However, when used appropriately, I'm satisfied that it can be used in a very safe way. Now, what do we conclude from this presentation? I think that a few points that I would like you to take home is, first, the thyroid system is hardwired to preserve serum T3 levels. And when we treat someone with hypothyroidism that we want that patient to restore to what they were before they had hypothyroidism, we're not looking at T3 levels. And for me, we have to change that, okay? It's really important to keep T3 levels within normal range, because The thyroid does that. The thyroid system does that and is telling us we should do the same thing. Now, levothyroxine-treated patients with normal TSH levels have relatively lower serum T3, as we saw, and higher serum T4. Many patients have serum T3 below normal range. So please, we need to focus on T3 levels. The idea that I treat patients with levothyroxine to normalize TSH, and I measure free T4 and TSH without even wondering, oh, how much is the T3 in this patient? I think we need to really rethink about that, and we should start focusing on T3 because that's what the thyroid system evolved to. Number 3, levothyroxine-treated patients exhibit residual cognitive symptoms and metabolic abnormalities. For many patients, this is clinically relevant. So we knew about this from a long time, but physicians said, well, these symptoms are not thyroid related because your TSH is normal. And now we know better. We know that even if you have a normal TSH, you could have cognitive and metabolic abnormalities as a result of us not restoring completely thyroid hormone homeostasis in these patients. I think doctors need to acknowledge that because that's based on science. It's based on serious science. And otherwise, patients will continue to complain of feeling neglected by the doctor. So I think doctors should acknowledge that, yeah, I understand that this situation exists. We don't know exactly why it occurs. We don't know exactly how to fix this, but we'll try with combination therapy. So we need to give more focus on patient symptoms in addition to measuring TSH and thyroid hormone levels in the circulation. In a subgroup of patients treated with levothyroxine, cognition and quality of life improve during combination therapy that includes T3. So that's there's data supporting this, and more than that, these patients prefer therapy that includes T3. So I think that physicians should go back and read the guidelines. Just read the guideline. I mean, I agree. The text of the guidelines could have been clearer, but that's what we have now. And if you read it carefully, you will understand that the guidelines are supportive of combination therapy for patients that remain symptomatic on levothyroxine. There's long-term safety data on the use of T3 in the treatment of hypothyroidism. This is a big deal. This was always a concern raised. Oh, I'm not sure, I'm giving T3, this is going to be dangerous. Well, there's long-term safety data showing that the correct use of T3 in the treatment of hypothyroidism is not associated with poor outcomes in these patients. So concerns about therapy with T3, appropriate therapy with T3, are not justified at this moment. As a result of all this, and again, just if you're not sure, go back and look the guidelines. The ATA, the ETA, so the American Thyroid Association, the European, and the British Thyroid Association opened the door for combination therapy for those patients that do not fully benefit from levothyroxine. And I think that that's a very important thing that we need to acknowledge. I'm going to stop here and move to the next segment, which is the Q&A. Thank you very much for having me.
Well, thank you very much, Dr. Bianco, for a very interesting and informative presentation. I think everybody's going to be paying close attention to what happens. I'd like to move on to our next section, and Hanista will now read the questions for Dr. Bianco. Again, please remember to only use the Q&A feature located at the bottom of your screen for your questions to the presenter. We will not respond to questions from the chat feature or from emails. So, Kanista, please.
Yes. So thank you again for your excellent presentation. And I just want to quickly say to the audience that a lot of questions are coming in, so we apologize in advance if we aren't able to get to your question. So our first question is, what are some possible options if someone is unable to tolerate T3 treatment, but continue to feel residual symptoms?
Well, usually, if you don't tolerate T3, it's probably because the dose of T3 is exaggerated, it's too high. If you use too much T3, and I think a good rule of thumb is to look at how much T3 we produce on a daily basis. Our system, counting the thyroid and the deiodinases, produce about 30 micrograms per day. So, and sometimes I have seen patients taking 400 micrograms of T3 per day, which is very high, of course. So if you take high levels of liothyronine, which is the pharmaceutical grade of T3, you might present palpitations, you become jittery, fine tremor. Usually that's the dose. I would recommend lowering the dose to a point that this should not be a problem. Remember, we produce 30 micrograms every day of T3.
Right, thank you. And our second question is, do you know if there's a connection between Graves' disease and cholesterol levels?
Well, Graves' disease is a form of hyperthyroidism, is an autoimmune form of hyperthyroidism. It's a situation that we have an excess of thyroid hormone in the circulation. Thyroid hormones, they act in the liver, lowering cholesterol levels. So usually patients with Graves' disease, when they have the activity of the disease, when they are hyperthyroid, they might have low levels of cholesterol in the circulation. But once they're controlled, supposedly the cholesterol will return to the normal range.
Thank you. The next question is, how long should a doctor observe a patient who is still symptomatic on levothyroxine until the introduction of cytomel or liothyronine becomes necessary?
That's a good question. It will depend doctor from doctor, but usually, let's say a patient had a total thyroidectomy and it's a benign disease, became hypothyroid. That patient will leave the hospital with levothyroxine so that they don't experience being completely hypothyroid. It will take between 4 and 6 weeks for the first adjustment to be made. So we wait until there's an equilibration, and maybe 1 or 2 more adjustments will be required. So I would think that about 6 months is a good time for the patient to see how things are, especially after having had surgery. If after 6 months things are not okay, the doctor and the patient should start discussing the possibility, first investigating other things. Maybe the patient has another disease that it's causing these symptoms. But if everything is excluded, after 6 months, I would start combination therapy.
That was all explained. Thank you. The next question is, if the body makes a total of 35 mcg of T3 a day, why do some patients need more T3 to feel well?
Well, the issue is that the 30 micrograms that the body produces every day, they are not produced all at once, right? They're produced slowly and released into the circulation. So if you take 1 tablet of 30 micrograms, the T3 is rapidly absorbed. There will be a peak of T3, and after a few hours, you don't have the T3 anymore. So unfortunately, the only way we have to use T3 today is this rapid absorbed form of T3. Some patients will use 2 doses of T3 per day, sometimes 3 doses. So you break down the doses of T3 in 2 or 3. Now, and now I'm going to say something that's totally based on my experience. 30 micrograms is a high dose for someone to be using in combination with levothyroxine, because you have to think that the levothyroxine that the patient is taking, it's also leading to some T3 being produced. So 30 is a little bit on the upper range. It's depending on the size of the patient, depending on the absorption. Maybe 30 is okay. I usually like to make sure the TSH is not below normal, because that will I will feel confident that the dose is not excessive. Now, some patients take only T3. I'm not advocating for that, but the reality is some patients do only take T3. And for those patients, then you need the dose to bring things back to normal is about 50 to 75 micrograms. But again, I'm not advocating for that, but the reality is there are a small number of patients that can only feel well by taking T3. If they take T4, they don't feel well. Maybe we don't understand exactly what they have. Maybe we need to study these patients more. But this is a reality, and that's how it is.
Right. So the next question actually relates to your answer. So someone asked, out of curiosity, in what cases would T3 monotherapy be beneficial to a patient?
I cannot think of any situation. The only thing I know is in real life, there are many patients that only take T3. Now, why? We don't understand. Maybe they have a genetic condition that favors their preference for T3 only. I don't know. I don't think we studied that much these patients. I don't think that's hypothyroidism is a very prevalent disease. In the US, there are about 20 million patients with hypothyroidism. So we have to be careful every time we say something. I just want to make absolutely sure the vast majority of these 20 million patients do very well on levothyroxine alone, okay? A small fraction of those patients require combination therapy. And a very, very tiny number of patients, I don't even know how many, but I see those patients in social media, I see those patients in my office. They come only taking T3. I'm not advocating for that, but why that is, I don't understand.
Thank you. And then the next question is, it's known that when T4 and T3 are too high or over range, problems can arise, such as atrial fibrillation or osteoporosis. It is not the TSH itself that causes them. So why do we rely on TSH testing instead of T3 and T4 testing?
Right, we should rely on both. I mean, I agree. TSH doesn't do any of that. TSH is an index that's telling us how much thyroid hormone is in the body. And it's a really good index. And that's why it's used so much. However, I already showed you in my presentation that we cannot trust TSH to tell us that T3 is normal in the circulation, because it's not. So I think we should always look at the TSH and look at the free T4 and T3 levels and patient symptoms to make a complete assessment of the situation. I think that's really important.
Right. Thank you. The next question is, some articles state that combination therapy is something we can try at our own risk due to limited research. So is there a safe way to approach combination therapy, such as a small dose first?
No, there's a lot of research on combination therapy. I just showed you 20 clinical trials showing that the effectiveness is the same as monotherapy and the safety is the same. So I don't think it can be at your own risk because doctors have to prescribe that for you. So I think that it's an agreement between you and your physician that you're going to try combination therapy. Now, yes, you should start with small doses. There's a formula to calculate the dose of, the physician will reduce the dose of levothyroxine and introduce a little bit of liothyronine, T3. How you do that, it's published. I mean, you can look at the 2012 European Thyroid Association guidelines. There's a beautiful formula worked out by Dr. Versinga in which he explains that. But I would leave that to the doctor to look at those numbers and discuss them with you.
Right. Thank you. So this is a question that pops up quite often. So how often should a patient under treatment for hypothyroidism see their doctor for a physical checkup? Many times prescriptions are refilled without the patient seeing or talking to their doctor about how they're doing.
Right. The patients that are doing well and have the residual symptoms, between 6 and 12 months, it's okay to see those patients. I mean, I think that it becomes like a routine visit, a checkup routine visit. Now, if those patients have residual symptoms that will require adjustment of the doses, those visits will need to be more frequent, maybe every 3 months. I think in some cases, maybe 2 months, depending on the intensity of the symptoms and the adjustments. But I would say a more intense follow-up would be every 3 months. Otherwise, it will be between 6 and 12 months.
Thank you. The next question is, how can women differentiate between menopause issues and low thyroid levels?
That's a good question. The laboratory will tell exactly what's happening. If the patient has hypothyroidism, then the biochemistry, the levels of TSH, T3, and T4 will tell that. If the patient is getting close to the menopause, which is called a perimenopause, the levels of estrogen will tend to be lower, and the levels of this hormone called FSH, follicle stimulating hormone, will be upregulated, will be high. So using this test, the doctor can tell if the period of the perimenopause is arriving, and those symptoms might be contributing to the whole picture.
Right. Thank you. How strong is the evidence that suppressed TSH with normal free thyroid 3 hormones and free thyroid 4 hormones presents risk?
That's a very good evidence, I have to say. We just heard a study that was published maybe a couple of years ago in which 500,000 patients in the VA system were studied, comparing levels of TSH and free T4. Unfortunately, that study did not have T3 levels because, again, doctors don't ask for T3 levels. And it was shown that the lower the TSH levels, the higher the risk that presented for overall health. So the cardiovascular outcomes and brain strokes were elevated as you lower the TSH levels. So I think in my idea is that we need to change the ratio of T4 and T3 in the circulation, bringing T4 down, T3 up, but always preserving serum TSH levels within the normal range. Having said that, some patients will just only feel well if the TSH is suppressed. And I think that instead of discharging that patient from the clinic, where we should try to talk to the patient and also follow up this patient, because some patients that have thyroid cancer have a suppressed TSH for many, many years in their lives. So I think that as long as we have a suppressed TSH, but with the intense follow-up with the doctor, together with the doctor, coming back every 3 months to making sure, you check your bone mineral density, you check everything, there's no side effect, there's no palpitation there. So, I think that in general, that's not good. We should avoid having a suppressed TSH. But for those exceptions, the patients only feel well once the TSH is suppressed. If there's an intense follow-up with doctors, that should be the preferred route.
Right, thank you. So this question keeps popping up by several attendees. So do you have any advice on how to get physicians to listen to patient experiences, especially when approaching combination therapy?
Advice to getting physicians to
listen to patients' experience.
I think patients should be brought to conferences to give their experience. I forget, maybe 10 years ago, I was part of the organization of a conference on hypothyroidism in which we brought 2 or 3 patients to talk to the physicians about their experience. Doctors are not used to that. It's sometimes doctors don't want to have that in their panel to discuss with patients, but that's one way to doing things. The other thing is these task forces nominated by professional societies to write clinical guidelines should have the input from patients. They should have 1 or 2 patients there, sitting there, bringing the opinion from a large group of patients. I think that this would change dramatically the way guidelines are written. Bring the input of patients and make those patients part. Again, this is not well accepted in academic medicine. Some colleagues of mine, in general, are not supportive of having patient voice in crafting clinical guidelines. But the reality is, we need, in my opinion, we need to have that voice to keep us focused on what's really important.
Thank you. No, I think that would be very great to implement.
Yeah.
So I want to be mindful of the time and respectful of your time as well. Do we have enough time for maybe 1 or 2 more questions?
Of course, yes, go ahead.
Okay, thank you. What is the role of TSH in patients who have no thyroid function?
0. The role of TSH in patients that have no thyroid is to be used by the doctor as an index how much thyroid hormone we should put in the system. A physiological role of TSH, I don't think there's anything really important. There's some studies showing that TSH can regulate some aspects of bone metabolism. This is highly controversial. Some scientists say yes, some scientists say no. There's some studies showing TSH could affect adipose tissue. Again, I think you see this in research. However, is this clinically relevant? No, it's not. So there's no role. It's just an index. It's a speedometer. So we know it's a number that we get to calibrate the dose of thyroid hormone replacement.
Right. Thank you. So this is going to be a little bit long, but in clinical practice, often when I prescribe T3, even modest doses like 5 micrograms will suppress TSH. I also find monitoring the T3 level is finicky as the levels varies greatly based on when the labs were taken compared to when the T3 was last taken. how do you titrate dosing? Do you use biochemistry at all, or do you only go off the clinical symptoms? If the latter, do you use a validated tool or just go off the patient's history?
Okay, lots of questions. Number one, when we introduce, this is obviously a physician or another kind of a health provider. When you introduce T3 liothyronate, you have to reduce the dose of levothyroxine. That you just don't add up, because if the patient has a normal TSH with a certain dose of levothyroxine, and we just add on top of that dose T3, you're going to suppress TSH right away, immediately. You have to lower the dose of levothyroxine. As an example, I would say you could lower 25 micrograms. If a patient is taking 100 mics of levothyroxine, you can lower to 75 and introduce 5 micrograms of T3 once or twice a day. But if you suppress TSH, you should lower the levothyroxine even further. So you need to create space so that you can introduce T3. Otherwise, you're going to suppress TSH. Now, T3 has a very rapid turnover rate. When do you measure it? Usually we measure in the morning, fasting, before taking anything, any tablets. So you're going to have a baseline of T3. And then you're going to measure 3 hours after the tablet of T3 was taken. So you have a baseline and you measure 3 hours later. 3 hours later is going to be the peak of T3 in the circulation. So you know the range, the full excursion of T3 in the circulation. And obviously, if at the peak you're going above the normal range, you should lower. This is not good. We don't want that. We accept the fluctuation of T3, but the fluctuation should be within the normal range of the T3 levels. So you're going to lower what? You're going to lower the T4, because if you're giving a small dose of T3, there's no way we're going to lower even more. So lower the T4, so you're going to bring this within the range. Now, the third part of the question, I will ask you to repeat, please, if you can.
Let me find it again, 1 second. So do you use biochemistry at all, or do you only go off of clinical symptoms?
No,
if the
biochemistry,
latter,
yes.
Do you use a validated tool or just go off the patient's history?
I don't use validated tools. I use the labs and I use the patient's symptoms. And I think that in the end, you need to, all of this needs to fit in a box, right? The lab needs to be okay and the patient needs to be symptom-free. That's the goal at the end. And it is possible because when the patient had a healthy thyroid, the labs were okay and the symptoms were not there. So we need to be creative and come up with a right dose to bring this back to the box.
Great. Thank you so much for answering and taking the time to answer all the questions in great detail.
My pleasure.
Thank you. I will now hand the mic back to Laz. Oh, I think you're muted, Laz.
Whew. I'd like to thank Dr. Bianco for giving us his presentation on rethinking hypothyroidism. We'd like to show our appreciation by awarding Dr. Bianco with a membership to the Thyroid Foundation of Canada. Thank you.
Thank you. Thank you so much.
I would also like to thank our webinar team for making this educational event a success. Thank you, team.
And thanks for having me.
Oh, thank you. It's our pleasure. I'd like to mention that if you have some spare time and would like to volunteer to help others with thyroid disease virtually from home, please call us on our helpline at 1-800-267-8822 or email us at info@thyroid.ca. You can also assist us by becoming a member or by making a donation by visiting our website at thyroid.ca. As you exit the session, please take a moment to complete our short survey. You will also have an opportunity to enter your comments. This will help us improve our future webinars. Our next webinar will be on April 30th. Dr. Franco Lopez will be speaking on Hashimoto's disease. All of us at the Thyroid Foundation of Canada hope to see you again soon. We hope you and your families are well and keeping safe. So goodbye, everyone. I hope you enjoyed our webinar. We'll see you in 2 weeks. Thank you again, Dr. Bianco. Appreciate it.
Thank you. Thank you for
Thank
having me.
you.
Goodbye, everyone.